Okay, Bappaditya, you can start.
Yeah. So, good morning once again. So, we have already discussed the acute management and chronic management, and I am left in between with the diagnosis. So, I am not going to the case once again. So, what was my provisional diagnosis? Are we dealing with a patient with acute heart failure with preserved ejection fraction, or we are dealing with something that is a preserved ejection fraction mimickers, or we are dealing with something that is a heart failure mimicker? So, atrial fibrillation, is there any other etiology? Moderate pH, what is the cause of moderate pH? Acute kidney injury, or it is an acute and chronic CKD? Hypoxia, we know that the patient is suffering most likely from heart failure, or there may be some components of COPD, and this in the form of hyponatremia and hyperkalemia. So diagnostic workup in ER, before doing a chronic workup, I need to do a diagnostic workup in the ER. So detailed analysis of ECG, look for STT changes, suggestive of ACS or AHD, ISD. In those cases, we may need to go for a TROP-T, TROP-I as CPK-CPK-MB, as the creatinine level is already raised. So TROP-I and CPK-MB appears to be a better choice for a cardiac marker in this patient. Echocardiography, we have already been given with two things, LVF 60% and PASP 50. We need to look into some other things. What are the things we need to look at? We need to look at this, the septal E prime velocity, the lateral E prime velocity, E by E prime ratio. If strain imaging is available, we need to look for global longitudinal strain. And two important things, the left atrial volume index and the left ventricular mass index. These are the other things that we need to look into the echocardiography. ABG, that already has been discussed, and a chest X-ray is a must for all patients presenting with dyspnea in the ER. Diagnostic workup in ICU, going by the American guideline, look for sepsis, anemia, thyroid parameters, lipid abnormalities, and the coagulation profile, because this patient will require a DWAC. So in this patient, we must look at the coagulation profile as well. So we also need to look at the iron profile in all patients of heart failure. USG whole abdomen, special reference to kidneys, because the patient is having AKI or a CKD, AKI on CKD. We need to look at the liver, unless we are missing something that is the heart failure mimicker. We need to look at the peritoneal collection in the form of ascites. Daily electrolytes and renal function is suggested. And once the acute heart failure component settles down, here where I come in. So is it a case of heart failure with preserved ejection fraction, or can it be something that mimics the heart failure with preserved ejection fraction? Let us do our workup. So when a patient presents to us with dyspnea or edema, we have to look at a non-cardiac source as well as apply the universal definition of heart failure. I believe this has been discussed yesterday, but I was not present here. I was in Singapore presenting cases in the ICD PCR. So just a quick look at the universal definition of heart failure, signs and symptoms of heart failure, and or functional abnormality and structural abnormality, together with raised levels of natriuretic peptides or objective evidence of cardiogenic, pulmonary, and systemic congestion. So in our patient, we have the symptoms of heart failure, but we have not proven structural and functional abnormality because LVF is 60%, and we have not been given the data about the structural abnormalities in the echo that I have already spoken about. And on the fact about the NT-proBNP levels, it is already raised. So then we apply the universal definition of heart failure. If the patient satisfies the universal definition of heart failure, we have to look for whether we are dealing with a heart failure with preserved ejection fraction or not. But I want to stress a few important things, that the natriuretic peptide levels may be raised in patients with heart failure as well as in patients with valvular heart disease, in patient of ACS, in patient of pericardial diseases, in AF, in myocarditis, as well as in anemia, renal failure, pulmonary causes such as severe pneumonia, in pulmonary hypertension, and critical illness. These are all the causes that may cause the raise in elevated natriuretic peptides. So when we are dealing with a patient with LVF 60%, we need to look at other structural abnormalities in the echocardiography. That is why a detailed echo is necessary in all patients with preserved ejection fraction where we are suspecting a preserved ejection fraction. Nextly, when you are suspecting a patient with heart failure with preserved ejection fraction, you assess the likelihood of the patient based on the heart failure with preserved ejection fraction score. What it is, we need to look at these following things. Whether the BMI is more than 30, the BMI is not given in this patient. I would ask the organizers for the BMI of the patient. The patient is having hypertension, whether he is on, whether she is on more than 2 antibiotic agents. The patient is having atrial fibrillation, 3 points for that. Pulmonary hypertension more than 50, 1 point for that. The patient is aged more than 60 years, 1 point for that. And the echocardiography, I would like to ask for the E by E prime ratio. If it is more than 9, then the patient satisfied the highly diagnostic criteria for HEP, because C will have 6 points for this, for the presentation that we have been given. So HEP, there are two important things why we are diagnosing a patient with HEP. Clinical diagnosis heart failure with LVF more than 50%, but which is not attributable to these following causes: infiltrative cardiomyopathy, hypertrophic cardiomyopathy, valvular disease, pericardial disease, and high output heart failure. If these things are not there, then we will term this patient as HEP. Otherwise, if these things are suspected and are proven on further investigations, this will be termed as HEP-PEP mimics. So these things should be kept in mind. The initial evaluation of heart failure, we have done all the things that the ACCH has recommended in my second slide. So how we are going to confirm our diagnosis of HEP-PEF? This is a very nice algorithm, the HFA-PEF diagnostic algorithm, which says to go for a pretest probability, signs and symptoms of heart failure, LVF more than 50%, and the structural and functional abnormalities. So this is the most beautiful thing of HEP-PEF diagnosis. The initial workup, you go for the symptoms and signs of heart failure, look for comorbidities, look for natriuretic peptides, ECG and standard echo. We have everything. Then for diagnostic workup, the confirmatory diagnosis, you have to do a comprehensive echo and a natriuretic peptides level. This is the comprehensive echo. For functional, there are major criteria that carries 2 points: septal E prime less than 7, lateral E prime less than 10, or FRT G by E prime more than 15, and a TI velocity more than 2.8. We have a TI velocity more than 2.8, so 2 points for the patient. Morphological, these are not given, so we have to look at these things, whether the LA volume index is more than 34 meter per meter square, or the LV mass index is more than 149. The biomarkers are given. I have HIP patient, the NT-proBNP more than 660. So for my patient, 4 points are there, 2 plus 2, 2 for this major biomarker criteria, 2 for the functional criteria. The morphological criteria, I have to look at the further comprehensive echo. If more than 5 points are satisfied, it is a HEP-PEF. If 2 to 4 points are there, we need to do for a diastolic stress test. I am not going to details of this patient because I believe if we get all the things, the patient will satisfy the criteria of the HEP-PEF. So here we are, HEP-PEF mimics, helpfully attributed to these following things. If these following things are suspected, then we have to go for other diagnostic criteria. If these are not there, the HEP-PEF, which is associated with hypertension in our patient, diabetes in our patient, atrial fibrillation, obesity, we do not know the BMI, and renal dysfunction is there. So our patient satisfies this criteria for this HEP-PEF. So what are the things we will look at? Other things, chest X-ray TT already given. In a patient with all these things, if we are suspecting ischemia, it is a class 2A recommendation to go for a coronary angiogram. And if coronary angiogram shows significant coronary disease, and if we believe the coronary disease is significant, more than 90% stenosis in a single coronary artery or in multiple coronary arteries, we can go for revascularization. If less than 90%, we can go for functional assessment, or we can go by stress echo or CMR or PET to determine whether there is ischemia or not. Then only we need to go for revascularization in the patient. Some other things, invasive hemodynamics to be done in patient where heart failure is persistent or worsening, and endomyocardial biopsy in patients where we are suspecting amyloidosis or sarcoidosis, such as the heart failure mimics, which I have already told. These are the important things for heart failure mimics. Cardiac amyloidosis, where we will suspect increased LV wall thickness. There is a sparkling appearance in echo and other musculoskeletal neuropathic issues. In those patients, we can go for monoclonal protein skin, endomyocardial biopsy, or a technetium pyrophosphate scan. For hypertrophic cardiomyopathy, we can go for a CMR. For cardiac sarcoidosis, we can go for a CMR, tissue biopsy, or FDG PET. So these are the things, particular things where we need to go for special investigations where we are suspecting. But in our patient, I believe we are suspecting we are actually diagnosing a patient with heart failure preserved reaction fraction, the true heart failure with preserved reaction fraction. Now coming to a few points about the atrial fibrillation in the patient, we do not know whether it is the first diagnosed case or not. But since we have not given in history, I believe it is the first diagnosed case of AF. So where we are diagnosing a patient with AF, we can go with this 4S AF scheme, where we have to look into these things for the AF of the patient: the stroke risk, the symptom severity, the severity burden of AF, and the substrate severity. This is where we need to do for other investigations such as TT, CT, or cardiac MRI for better management of the patient with atrial fibrillation. These are the extra things that we need to look for managing AF better: the CMR of the LA for decision making in AF treatment, and a CT, coronary CT angio if we are suspecting a CAD, unless we do not have done invasive coronary angiogram. These are the things that we need to look for the AF, for managing the AF of this patient. A TE may be required to see whether there is a clot in the LA or not. Cardiac MRI and EP mapping for better evaluation and assessment of the AF in the patient. These two important things I want to stress: the pH, where we are looking into the pH, non-invasive assessment compatible with pH. Yes, it is there. We need to look at the important things, whether there is a lung disease or not, and left heart disease is already confirmed. For assessment of lung disease, we may need to do a PFT and HSCT. I am not going to the other things about the pH. Regarding the CKD, we have to look important things. I always look at these things, whether I'm dealing with an acute CKD or a chronic CKD. So we look at the hemoglobin, the renal size, the renal osteometry parameters, the intact parathormone, calcium, and the phosphate, and whether the serum creatinine levels come back to normal or not. So while we are decisioning the patient, we need to look a few things about the scores, the IPSA score, the TopSCAT score, and this scores regarding the acute decompensated heart failure for better assessment of the patient. Coming to my take-home messages, emergency evaluation and management is top priority in patients coming to ER with acute shortness of breath or decompensated heart failure. After stabilization of the patient, thoroughly evaluate for the provisional and differential diagnosis. Diagnosis of HepPEF is sometimes difficult. Following the HepPEF algorithm is very helpful. HepPEF mimics and HepPEF attributable to specific causes should always be looked into. Special investigations should be done, and assessment of specific risk scores help to predict short and long-term outcomes. Thank you, and thank you, organizers, for giving me the second chance to speak my seminar. Thank you.
Okay, thank you.